Hello everyone and welcome back to Medi Notes for Medicos. The topic that we're going to deal today is about tuberculosis from microbiology respiratory system. The objectives being causative agent, antigenic structure, pathogenesis, clinical manifestation, lab diagnosis, treatment and case study. So the causative agent of tuberculosis is Mycobacterium tuberculosis. The antigenic structure is divided into two forms. One is the cell wall antigen that is insoluble in nature and cytoplasmic soluble layer. Now, the cell wall insoluble antigen, it has various layers. So, first layer being the peptidoglycan layer. This layer ensures that there is rigidity and shape to the cell. Now, arabinogalactan layer is the one that is very important component of the mycobacterial cell wall. Mycolic acid layer is the one that ensures acid fastenings and also it prevents the entry of the drug into the cell wall. The outermost layer consists of lipids, glycolipids and mycocytes. The plasma membrane over here is located below the cell wall and other proteins, for example phosphatidyl inositol monocytes and LAM. This LAM, it acts as target antigen for TB diagnosis. This is a very important point. It acts as a target antigen for the TB diagnosis. It is the one that is responsible for the facilitation of the survival of tubercle bacilli. In the proteins, these proteins are found throughout the various layers. Next one is the cytoplasmic soluble layer. It has antigen 6, antigen 5 and antigen 60. These are responsible for the serodiagnosis of the TB. Next is the pathogenesis. So how is this, what is the source of this disease? The source is infected human beings or bovine source. Bovine source means consumption of unpasteurized milk. The mode of transmission is aerosols, inoculation and ingestion. Aerosols in the meaning while an infected person is standing near you and coughing or sneezing or speaking, the droplets would be transmitted into the air that would be inhaled by us. So this aerosols is one of it. Inoculation is direct contact with an infected person's body. This occurs very uncommonly. Ingestion in the sense is if in case of children they swallow the sputum, and in other cases in grown up we drink unpasteurized milk, so this can lead into TB. Now what are the risk factors? Now if the patient is showing a positive sputum test, it is more effective comparing to the patients that shows a negative sputum test. Now the bacilli load, if it is less than 10 to the power 4, it is all right. It is not as dangerous as the bacilli load that is more than 10 to the power 4 bacilli per milliliter in the sputum. Next is the overcrowding in when in overventilated room. Then in low cell mediated immunity people, for example in people who have HIV infections. Next is the age. In age, when we see, it is mostly prevalent in late adolescence, early adulthood periods and in old people. In other comorbid conditions like diabetes, post-silicosis, renal failure in those cases, and sex in the sense the females having the age from 25 to 34 and the male who are old in age. Now we learn about the sequence of pathogenesis, like how is this pathogenesis occurring. So the first thing is the inhalation of the infected aerosols. So once the infection once we uh, inhale these aerosols, majority of them it gets trapped in the upper airway, and from there what happens is that out, because of the ciliary action of the mucosal cells, it gets expelled out. But then a partial of this aerosols, it goes into the alveoli. Once in the alveoli, this I told you about a LAM protein over there in present in the mycobacterium cell. So this LAM present in the mycobacterium cell, it binds out to the complement receptors and the mannose receptors that is present on the surface of the macrophages present over there. Now once they are binded to the macrophages, internalization of the bacilli occurs. Now once the bacilli enters inside the macrophage, phagocytosis occurs because macrophage detects an unwanted body in it. And how does the phagocytosis process occurs is by complement C3b mediated opsonization of the bacilli. After which what happens is there is an impairment of the phagosome lysosome fusion. How does they impair this? By inhibiting an increase of the calcium and phosphatidyl ionositol 3-phosphate. Once this impairment is done, it enables the bacilli to survive in that medium. And survival of the mycobacteria in the macrophages is enabled, and then some of them would be successful in arresting the fusion that's going to take place, while some of them won't be able to. So in the case when they are unable to arrest it, those people would get uninfected. They would move away from there, like they would not get infected by it. However, if the possibility of arresting of phagolysosome fusion by bacilli is accomplished, they would replicate the mycobacterium inside the macrophages. Once the replication process is over, the macrophages ruptures and the bacilli it flows out of the macrophages. After the rupture, the bacilli is out freely in the bloodstream, and this goes and infects the uninfected pathogens. Once the uninfected pathogens is infected, the cycle continues again. Next is the clinical manifestation. So TB is divided into two forms. One is the pulmonary TB, other one is the extrapulmonary TB. And the pulmonary TB is further divided into primary TB and post-primary TB. Now, the extrapulmonary TB has various sorts of TB in it. It would be tuberculosis elephantiasis. This occurs mainly in children, and they occur at posterior cervical supraclavicular lymph nodes. It is painless, and the swelling won't have any color change or any warmth. Next is the pleural TB. It generally it presents itself as pleural effusion. Then we have TB of airways, genitourinary TB, skeletal TB, CNS TB, GIT TB, etc. uh, Next, the most important one I want to bring in your concern is HIV associated TB. Whenever a patient that approaches to you, they have HIV and they are having continuous cough along with weight loss, you have to rule out TB from it, because TB is one of the opportunistic infection that occurs in HIV. Now there is another manifestation that we need to keep in mind is the barrel shaped chest that is caused by tuberculosis. Next we'll be seeing the full symptoms. You will be having poor appetite, miliary tuberculosis. Miliary tuberculosis is in cases of in cases when there is granulomatous lesions, it would be in the shape of millet seeds. So the color of that seed would be yellowish in color, and it would be ranging to 1 to 2 millimeter in size. They are mostly seen in HIV patients. So this would cause weakness, fever, dry cough, night sweats, weight loss, gastrointestinal symptoms, chest pain, structural abnormalities like I said, barrel shaped chest, productive cough with increasing mucus, sometimes cough with blood comes off in extreme cases. Then we have meninges, lymph nodes, bone and joint sites, genitourinary tract, all these things comes under it. Now we'll go into the lab diagnosis, which is the most important thing of the tuberculosis. So the specimen that we collect over here for pulmonary tuberculosis would be sputum and gastric aspiratory in children. So the sputum, we would take two samples, one in the on spot, or and the second would be early morning. Now we'll be doing the next step, that is digestion, decontamination and concentration of the specimen. So how are we going to do the digestion and decontamination? We'll be using modified Petrov's method. In modified Petrov's method, we will be using 4% of NaOH, and this one is recommended for Lowenstein Jensen medium only. The next one is N-acetyl L-cysteine along with 2-NaOH. This one helps in liquefaction of the sputum, and here the NaOH, it kills the normal flora. Now we'll be looking into the direct microscopy. Here, direct microscopy, it would be using Zeal-Nelson technique, Kinyon's cold acid fast staining and fluorescent staining. In under Zeal-Nelson technique, we find out long, slender, beaded, less uniformly stained and colored red color acid fast bacilli. And in fluorescent staining, which is also known as auramine staining, it is more sensitive, and the smears over here are screened rapidly comparing to the uh, Zeal-Nelson technique. Now, culture is divided into two forms. One is the conventional and other is the automated. Under conventional, we have Lowenstein's Jensen medium. This takes around 6 to 8 weeks for providing the correct diagnosis. And once the results come out, the results will be seen as rough, tough, and buff colored colonies. In automated, culture method, we have Bactec MGIT system. So MGIT means Mycobacteria Growth Indicator Tube. So in Bactec MGIT, the growth as well as resistance is seen. Then we have the culture identification method by Maltitov method. Antigen detection is done by ICT. Next, we have the molecular methods. For molecular methods, we'll be using PCR detecting IS 600 and 6110 gene, CB-NAT. Then we have TrueNAT, chip-based NAT, line probe assay. CB-NAT is the most commonly used method now for detecting, because CB-NAT is also known as Gene Expert, and TrueNAT. These both takes just 2 hours to detect the mycobacterium presence, unlike the Lowenstein-Jensen medium. Next, we have in latent TB, we have Mantox test, and we have interferon gamma rose assay. So now in Mantox test, what happens is, it's also known as tuberculin skin test. Here we use antigen PPD, and we use PPD 23, and we perform TST here, that is tuberculin skin test. The dosage is 1 TU. 1 TU means 1 tuberculin unit, that is 0.0002 mg ppd. The procedure is, we use 5 TU, that is 0.1 milliliter of ppd intradermally in the flexor surface of the forearm, and the reading would be given at 48 to 72 hours. So the inoculation site over here would show some sort of induration that is surrounded with erythema. If the erythema is less than 10 millimeter, if it is greater than 10 millimeter, then it is positive. If it is 6 to 9 millimeter, then it is doubtful. If we have below 6 millimeter, then it is negative sign. Now we have the serology over here, which is not recommended because of its low sensitivity. In X-ray, we find irregular patches. Now I'll be looking into the treatment. We'll go for multi-drug treatment. Multi-drug treatment consists of ripe mnemonics, that is isocyanate, rifampicin or rifampin, pyrazinamide, ethambutol, and streptomycin. Now we have USDT over here. USDT means universal drug susceptibility testing. This is a very important thing that we should do before the treatment, because it helps us to detect any sort of resistance in the patients, like at least to rifampicin or rifampin. Then we have short course therapy, that is for 6 months or longer. Here we will be using the second line drugs, for example levofloxacin, clofazimine, streptomycin, etc. Then we have the two-phase chemotherapy. Two-phase chemotherapy is divided into two groups, that is intensive phase and continuation phase. In intensive phase, we give aggressive treatment to the patient with multiple ATDS, and then when we smear it, we find it negative rapidly. When we have the continuation phase over here, we kill the remaining dormant bacilli so that we can prevent a relapse or the reoccurrence of this disease. Then we have dot strategy. So dot strategy means directly observed treatment for short course. So for here, the entire treatment should be supervised to improve the patient's compliance, and then the treatment response would be monitored by sputum smear microscopy at end of each phase. This dot strategy is the strategy that is followed presently by WHO. So we'll go into the case study here. I have given two cases which indicates the tuberculosis case. One says about 21-year-old gentleman from Bangladesh, which is a developing country, living in a shared flat with friends. Shared flat with friends, so either of them can have an infection. Presents with 2 months history of a productive cough, associated fever, drenching night sweats. Here we have night sweats, productive cough, loss of appetite, and a 5 kg weight loss. Next one is a 44-year-old man present with the symptoms of progressive shortness of breath and cough with greenish sputum production. He was HIV positive too. This both indicates the presence of Mycobacterium tuberculosis, and it is a case of tuberculosis. So that was the video for today. I hope you like this video. If you like this video, don't forget to like, share and subscribe to the channel. We'll be coming with more videos. Still then, stay tuned. Happy learning. This is Ashna Viraju signing off for today. Bye.